Hi, welcome to our second care coordination meeting. I can't believe it's already May. If you don't know who I am, I'm Caitlyn Johnson. I am one of the project managers for Arkansas Behavioral Health Integration Network, and I am in my role of care coordinator today. So we are going to go over a couple of different things. But to begin, we're going to go over our last care coordination meeting. Just to recap, make sure there weren't any questions or any needs from last time, and to make sure we stay on the same track and understand where we're going with our efforts here. We're also going to address the action meeting or action items from last meeting, just to make sure that the development of the care compacts didn't cause any obstacles for anyone, or if anyone had any questions, we can go ahead and address those via email if needed. We're going to talk about creating those conversations with specialty offices as well. So now that we have a care compact, how do we have a conversation with these offices we want to talk with? And then we will briefly touch on some resources we recently learned about that may be helpful for you and your clients and your patients as you meet with them regarding tobacco cessation. And then, of course, we will address next meeting. When is that coming up? That will be in August, and I will send a meeting invite for that. So just like we talked last time, in case you weren't able to tune into that presentation, we talked a little bit about why care coordination is our focus. What's the point of even bringing care coordination into the conversation when talking about suicidality in primary care and workflows within primary care offices? So just to recap on that, there was a study done by the American Journal of Care Management that showed one system's effort of care coordination to have reduced spending significantly within their Medicaid population. So not only were they able to decrease the admission rate, but they were also able to decrease the length of stay. So how long the patient was admitted for overall. And they were able to decrease the patient's medical costs by $7,700 per patient. I mean, that is astronomical, especially when you think about patients' out-of-pocket responsibilities and the stress of just being in the hospital regardless. So if we can decrease that at all, that'll be extremely helpful for their financial situation and for their mental health. So we go farther down, we can see that they reduced the inpatient utilization by 59%. So that's over 0.5% by just making a concentrated effort with their care coordinators. And then overall admission was decreased by 44%, which is just about half. Another point that they made is that also within this intervention, they were able to decrease the bed days, but then they were also able to decrease visits to specialty offices. And I'm sure with our Medicaid populations and our Medicare populations, one of them has to pay a copay every time they go see someone. And then the other population only gets about 12 visits a year. So you're going and seeing a bunch of different specialists, and you need to come back and see your PCP. It can take up a lot of your money, and it can take up a lot of the resources that you have within your insurance. So using care coordination, they were able to decrease the patient's specialist visits by enhancing primary care engagement. So making sure they were able to cover as many boxes as possible in topics with their primary care physician and care coordinator while they're in the office to decrease the need of extra resource utilization. And on this third bullet point here, you can see that ultimately it has the downstream effects of increased engagement, but it also has the better management of overall chronic condition. So it's not that we don't want them to see their specialist, we just want to make sure that the patient is empowered to do as much as they can. So just to give a little bit of recap on why we are talking about care coordination and how care coordinators can play such a vital role in patient care. Okay, so our last care coordination meeting was in February, and we talked about care compacts and how care coordinators can use this tool in order to make change within the conversation between the specialty office and the primary care office. Just a quick recap on that. So care compacts are formalized agreements between PCPs and specialists that designate referral protocols, care management responsibilities, and care transition expectations. An important thing that's not listed on here to know is that it's not a legal agreement. It's not anything that is legally binding. It is honestly just a formalized, put together way to address some of the referral obstacles that people usually run into. So sharing records and knowing who's responsible for what medication and what the primary care office will help with. Care compact development. So looking at February's action items, we encouraged you and challenged you to come up with a kind of a skeleton draft of what a care compact may look like for you. And I know we have some in the consortium that have already used a care compact before. And then I know we have others that have only had a conversation with the offices that they work with, and they don't have a formalized one. So we're all starting at different places, but the best place to start is a brand new rough draft just to see what can a behavioral health specialty office help us in accomplishing. So as we consider the draft that you made, if you want to take a moment and pause this video, I do ask a couple of questions. The first one is, what needs did you identify as important to incorporate? This is looking at, is there anything different from previous care compacts that you've used to make sure you put into this draft that's specifically with behavioral health? Were there any obstacles that you experienced when creating it? Did you run into any writer's block? Did you run into anything that may have made it difficult for you to make this draft? And of course, since we're on a recording, we are not able to share our screens right now, but if you do come across us and you are running into some obstacles, we are available by phone or by email, and I would be happy to help you with that. So just to give a quick recap on what a care compact looks like, I do have an example over there on the right. This is something that I created with ALiNC on what a possible section of a care compact can look like, but we also have other examples here. These may look familiar if you were able to tune into last month's meeting, but if not, just wanted to do a quick overview on what different care compacts can look like. This is just one example. This was done by a health system in Colorado, and they really were very thorough with their care compact. So here you can see as I go down the screen that they went over purpose, principles, definitions, anything that they could have thought could be confusing or misinterpreted in their care compact, they made sure they put on there. They even discussed types of care management transition. So whether or not they're talking before they transferred the patient, while the patient's in care with the specialty office, or when the specialty office gave care back over to the primary care office. Just continue down, and it's more definitions. We come into, as we go down, we come into the actual care compact itself. So you can see that the example I had on the slide and the example I'm showing here are very similar. The makeup of their care compact, it flows very well, but yours can look just like a checklist. Yours necessarily doesn't have to have the borders and everything like that. If that's the population you work with, as far as you want it to be simple and to the point, that is also an option as well. But here you can see that they are addressing transition of care, what access is available both on the PCP side and the specialty care side. Keep going down, collaborative care management, what it's going to look like for both the care coordinator on the PCP side and who acts as the care coordinator on the specialty side. And then how can the patient communicate with their doctor. So over here on the, this is a little unique. Over here on the PCP side, it details that, the PCP is going to explain why they're sending them to the specialist. They're going to give them the information that they need, the address, the phone number, when the appointment is, if they've scheduled it for them. And then specialty care is agreeing to, really sit down and educate the patient on their diagnosis, and then communicate back to the primary care office for follow-up. Another unique thing that they have in here is that they have an additional agreements and edits section. So of course you want to make sure that these care compacts are as collaborative as possible. Not everything that you put on your compact is going to fit the needs of the specialty office, which is fine. And that's the point of the conversation that we're having, right? So being able to leave a area of the care compact that allows for some changes to be made may make the specialty office feel even more at ease expressing their needs with you, to knowing that you are willing to listen to that. So this is just one example of what a care compact can look like. Again, they have a whole bunch of definitions and references here in the back. I will be sending this out with the slides, so don't worry about having to remember all of that right now. But that will be included in the email. Okay. So moving on, now that we've got an idea of what a care compact can look like and how to frame it, we want to know how we approach the specialty offices. So here is where I would ask you, who are the different players on this team, but it's a little bit of a trick question. Okay, so when we consider the specialty care office, there are all kinds of people who work there, just like there's all kinds of people who work at the PCP's office. So when we're considering having this conversation, we really want to rope everyone in. We could have a provider, a PCP provider, know the psychiatrist over at the community mental health center because they ended up going to school together, or the front desk staff could know each other due to making other referrals. You've got nurses who could have went to school together. There are a lot of opportunities that present itself by just who you know, what connections you make, especially in rural areas like we have in Arkansas. Connection is such an important thing, and a lot of people know each other. You've got clinic managers, their kids can play soccer together or play baseball together. So being able to rope everyone in and have that quick conversation of, hey, I'm about to have a conversation about a care compact and being collaborative with this clinic. Does anyone know anyone over there? Does anyone have a strong relationship over there? Another point is that each one of these players on this team, the care coordinators, the RPAs, the front office staff, they're all going to have different goals in mind. So when you discuss the possibility of reaching out to another clinic and check if they know anyone over there, there's also a conversation of, when you're getting referrals or communication back from the specialty offices, what could be helpful, and help them or allow them to influence the care compact as well, which will help make a even smoother workflow for everyone, as with everyone's needs being met. The next question is, after we've identified who the players are on the team as far as starting this conversation, we want to ask how we form this alliance, right? How would we want to be approached for a partnership if we were on the receiving end of this? Okay, and I kind of compare it to a drug rep. I don't want to view us as drug reps, but we view it as who is your most memorable rep? Is it the people that just come in and just talk to the doctor and then leave some samples and leave? Or is it the ones that bring food and bring freebies like pens and chapstick and things like that we remember? Now, it's not necessarily like we have to bribe them at all. It's just talking about how we bring something to the table. So our most memorable reps, they bring something to the table. They're personable. They want to know you. This is the same type of situation. Just like we're asking a lot out of our specialty offices by sending us charts and by communicating with us and maybe allowing for certain amount of time for emergency appointments on their schedule, we want to make sure we bring something to the table as well. So being able to say, yes, we will leave an opening on our schedule, every day or every week for emergency patients to get in to do their PCP, or we will make sure anytime there's a medication update, we will send it to you. You want to make sure that collaboration, it's not just us asking them something, it's us giving something to them as well. So now that we know the players and how we would want to approach them, how would we physically approach the conversation with them? So there's a couple of different ways. I've worked with care coordinators who type up a nice letter and they fax over the care compact with a cover sheet and just wait for a response on them, and maybe make a phone call a week later, just making sure, hey, did you get my care compact? What do you think about it? And then there are some care coordinators that I've worked with that have really sought out, like the clinic manager, the care coordinator in that office, or maybe a nurse that they knew or something, and asked for a face-to-face discussion with them to make sure that they understand what the care compact is and that it's not misconstrued or misinterpreted. Either of these approaches would be fine. You really have to take a look at who you're working with and what your population looks like and what your community looks like to see which one is the best for you. They're really knowing who you're working with at that point really isn't a wrong way to go about it. Just making sure you meet the needs of theirs. Okay, and another thing that we usually want to address when we're approaching specialty offices is HIPAA, right? What is covered by HIPAA? Are we allowed to get notes back from behavioral health? Are we allowed to send notes to them? What do we do if they, are a little bit stingy with giving us the charts and things like that? So it's better to kind of get ahead of one of those things that you know is probably going to be a stumbling block, an obstacle for you with a specialty clinic. And this is an opportunity to share some information with them when you're discussing the care compact. So we have a really convenient handout here. If I can get to it, will maybe handout here that lets us show what is covered under HIPAA, what's allowed, and what we're asking for and what we're not asking for. And I find this to be a pretty easy way and non-confrontational way to say, hey, we can have those notes. We're all covered. We're safe, and it lets them understand what covers HIPAA. Or is covered under HIPAA, I'm sorry. So this is just a quick handout. It also comes in a brochure form that you can fold and give to someone. This is all the do's and don'ts of sharing information between agencies. So over here on the right, you can see there's a really quick rundown on do's and don'ts. You can collaborate to provide good patient care. Don't assume that you can't share information. Don't confuse psychotherapy notes with progress notes. So like I said, over there's a quick rundown, but then you come over here to the left, and the main focus of this handout is the references to the actual HIPAA laws and definitions of them. So what this does is help outline that what notes are safe, what we can share, what you can share, and then what is actually being requested when we request those notes. So not only does it give a good idea of what is covered under HIPAA, but it also puts their anxiety to rest. We all work in healthcare. We know how scary HIPAA is sometimes, and the laws around that. So it makes us a little nervous. It's understandable, but this is something that I will also send out, as well as the brochure form, just for you guys to use as a resource as you approach these different behavioral health offices. Okay. So we went over a couple of things. Of course, I'm going to challenge you with some action steps for our next care coordination meeting. We want to make sure that we have some final edits ready to, I'm sorry, that didn't start me over, ready to share with the rest of the group. So as we've discussed what a draft could look like and who you would want to influence some of the care compact information, in August, we'll go over some final edits and clean it up a little bit and be able to ask the group, what changes do you find important? And then we also encourage you to start the list of the clinics that you would like to collaborate with. Now, if you're in a rural area and you only have the community mental health center, maybe you have that in a private office, you may not have too much to choose from, and that may be what your list consists of. That is totally fine. Just make sure that you've identified those clinics and maybe you've gotten an idea of how you would like to approach them. And of course, it's August, the kids are out of school. You want to have some fun. So go make sure you practice some self-care and enjoy some summer fun. Okay, so to wrap us up, I'm going to discuss real quick a resource that recently came on our radar. So this is a tobacco cessation website that's done by the state that is just full of resources on how to help your patient stop using tobacco. So not only are there handouts on the Be Well Arkansas website, but there's also a way to connect your patients to counselors for tobacco cessation. So if you in your clinic don't have the capacity or the ability to sit down and do tobacco cessation with each patient that comes in, I understand that, you know, that's kind of a big thing to sign up for. This is a resource that you can use in order to help supplement the efforts that you're already doing. So as you can see, I'll just go over this real quick. You know, there's different sections. You know, is the patient thinking about quitting? What stage of change are they in, right? Are they thinking about quitting? They already know their quit day, they've recently quit, or they're looking to sustain their tobacco quitting. So that is a option there. They also have some education on diabetes and how it's linked to smoking tobacco. And then of course there is a healthcare provider section. In my personal opinion, an awesome part of this is that you can refer your patients online. Of course, you want to have the permission of your patient. You may want to do it while they're there, but you can do it online, or you can download a fax referral form. I have personally used this resource before. They're usually very responsive, and I've heard good things about the experiences from my patients. A big thing about them is that they will help your patient get nicotine replacement. So you're looking at the gum or the patches or anything like that. They can help your patient afford that, whether it's a significant discount or for free. So that is also a good resource to know that for our patients that are struggling to quit because they can't afford the aid. This is something that you can use for that as well. Okay, and that also, when I send out the slide deck, that will be included. You can just click on that link. Okay, well, we have finished the care coordination meeting for this time. If you have any questions, my email and my contact information, my phone number should be available to you. I'll make sure I send it out again. Feel free to contact me with any questions and I will get back to you as soon as I can. Thanks.